Hi everybody, I hope you had a great lunch and not everybody's too sleepy before we start. Thanks for inviting us here today for the opportunity to speak about our service. I'm Liz, I'm one of the dietitians that work in the major trauma service and the hyperacute service at the Queen Elizabeth Hospital here in Glasgow. And this is my colleague Claire, who's one of the occupational therapists working for the hyperacute service. As the title suggests, we're a new service in Greater Glasgow and Clyde and the only one in Scotland, so we're kind of one of a kind. Today we'd like to tell you a little bit about our service, and we've spent the last few months introducing ourselves to other teams, making links with other health and social care teams, so we're delighted to come here today and introduce our unique service to you. Before we start, we better explain a little bit about why we've given the presentation title of Keep Calm and Carry On. I'm sure you can imagine with any new venture and setting up any new service, there's been a variety of emotions from everybody, but thankfully not all at the same time. There's a lot of running about, talking to other teams, networking. There is some despair at times when things don't go quite as we expected them to go. A little bit of anxiety and confusion for the unknown. We're a new service. We're not too sure what we're doing. We're feeling our way as we go. But this has led to some great thinking, some light bulb moments for the team, and the occasional moment of calm and reflection. But with all that going on in the background, we have to make sure we keep our patients at the centre of our care. We need to remain focused and the main goal of providing our high-quality, patient-centred care. Like I said, the service is relatively new and we're still evolving. We're learning every day. We're continuing to develop our team, our processes, and the care we provide. As the title said, also, we're part of the wider major trauma service. But what does the hyperacute bit mean? It's a little bit confusing. But for us, what it means is that we see patients as early as possible in their hospital stay and we provide them with the most appropriate therapy interventions as quickly as possible. But where did we all come from? So, we're part of the Scottish Trauma Network, which is a network of Scottish hospitals that provide care for patients after traumatic injury. Scotland is split into 4 regions, the East, North, South East and West. And we are part of the West region, which opened in 2021. I don't know if you can see the little green dots on this map behind me are the West region. It's a hub and spoke model, so the Queen Elizabeth is the main centre and we feed in from other hospitals that cover Glasgow, Clyde, Lanarkshire, Ayrshire and Arran. We also get patients from the Highlands and Islands, and we sometimes get patients from Forth Valley too. Even though they're on the border of East and West, sometimes it's geographically easier to come over to the West for them. The network was set up following a report from the Chief Medical Officer in 2017 to provide early intensive rehabilitation, to provide a level of care that significantly improved outcomes and allowed patients to return to their lives as independently as possible. We know that early rehabilitation with increased intensity leads to better patient outcomes. So the ethos of the Scottish Trauma Network is not only saving lives, but giving life back. So you can find a little bit more information about the STN via the QR code here. So how we set the service up? It was recognised that there was a specific group of trauma patients who were admitted that would require a slightly different type of care due to their injuries. When money from Scottish Government was released, a designated hyperacute service was set up as part of the wider trauma team. We have an allied health professional consultant who's a physio to trade, who was already employed within the trauma team, and she oversees and manages the hyperacute service. She looked into what other centres had done in England, and from that, and in conjunction with national guidelines, there was a staffing complement that was calculated, and it was identified that members of the team would be required from a variety of professionals. So when money was released, jobs were advertised, the recruitment process commenced, and staff were appointed last year. The proposed funding was for a designated 12-bedded ward, but as of yet, we don't have a physical space. We're required to provide our service on an in-reach basis across multiple wards at the Queen Elizabeth. So we're a very small but happy therapy team based at the Queen Elizabeth Hospital on the first floor in the Major Trauma Centre. It's not our home all of our working day because, as I said, we provide an in-reach service across the hospital. We're made up of allied health professions, and at present we don't have a designated medic or nursing complement within our team, but we work closely with rehab medicine consultants and staff in wards where we see patients. We provide an in-reach service, meaning we come to the patients wherever they are in the hospital. They could be in numerous types of wards, including critical care, neurosurgical wards, in our own major trauma ward, or in general wards. We have a small caseload of only 6 patients at the moment, and we are an interdisciplinary team. We work very closely together. We're made up of a variety of professions, from a variety of different grades, and from a variety of different backgrounds. So we have an allied health professions consultant who oversees the clinical work that we do. There's dietitians, including myself, who ensure patients have the right nutrition to support their recovery and rehabilitation. We have neuropsychologists who support patients' mental health and well-being, occupational therapists who support patients in relation to memory and everyday activities and tasks, physiotherapists who support patients with their mobility and joint range of movement, speech and language therapists who support patients with their swallowing and communication, and last but not least, we have our therapy support workers who support the therapists to do their role, and they support patients with the activities that they enjoy. They definitely bring the joy to our team and are invaluable members. So the hyperacute, is it there? The hyperacute service was established last year in April 2023 after funding was released from the Scottish Government. This additional money was provided to establish further trauma services for patients that had sustained a traumatic mechanism of injury. We treat a specific group of patients admitted under the umbrella term of trauma, but these can range from the walking wounded to those with significant head injuries, including those in prolonged disorders of consciousness. The patients are usually screened using a specific tool known as a Patient Categorization Assessment Tool, or PCAT, and are classified with what's known as Category A needs, according to the British Society of Rehabilitation Medicine. So what is Category A? Oh, apologies. The definition of Category A patient, as per the British Society of Rehabilitation Medicine, is typically someone who, with a severe physical, cognitive, communicative disabilities or challenging behaviours, with highly complex rehabilitation needs that are beyond the scope of their local specialist rehabilitation service and need higher level facilities and staff to support these. This means that the needs of these patients are unlikely to be met by standard ward level care and staffing complement. Our staff to patient ratio is significantly different than a general ward and is based on the British Society of Rehabilitation Medicine guidelines. As I said before, we have a range of patients that we treat, from the walking wounded to those that are in prolonged disorders of consciousness. Our team has a wealth of specialist neuro experience and provides very intense rehabilitation from multiple disciplines on a daily basis, and we often see patients for multiple interventions daily.
So who do we treat? We treat patients who are on the Queen Elizabeth site. They have to have a traumatic mechanism of injury, including a traumatic brain injury. Patients are screened using the PCAT, which, as Liz said, is the Patient Categorization Assessment Tool, and they have to have a score of grade 30 or above. This tool covers questions in relation to current care needs. It is a list of 17 questions covering medical, neuropsychology needs, along with physical needs, swallow needs, communication and cognitive needs, as well as social needs. Each need is allocated a score from 1 to 3. and the length of predicted stay is also considered and scored. Overall score is out of 50, and we treat patients with a score of greater than or equal to 30. The patient requires to have input from 3 or more of the therapy professions within the team. Our patients have complex past medical histories and social circumstances that we also require to take into consideration to ensure that they can engage in early intensive rehabilitation. So how do we work? Referrals can be from anyone in the hospital. Our main referral source at present are the head injury advanced practitioners who are based in the Institute and are aware of all admissions to the hospital and highlight any patients with head injuries who may benefit from input with our service. Patients are screened once medically stable. There might be a number of days delay between referral and screening, as it is important that patients are medically optimised, which means that they're well enough for us to have input with them. 2 members of our team complete the screening process. The screening includes 1 senior and preferably 2 staff members from 2 different professions. The PCAT is scored, and as I said, it needs to be greater than or equal to 30 to be accepted with our team. If it's not above 30, we speak with the ward staff and therapy teams for the continuation of care within the service or ward that they are on. Once the patient has been accepted, the whole team will assess the patient from their individual professions. We allocate a key worker who acts as the main point of contact for the patient, next of kin, family and staff. The key worker can be from any profession within the team. We organise regular update meetings and link in with local trauma coordinators and ensure all appropriate transfer and discharge paperwork is shared with the relevant staff on discharge or transfer to specialist rehab or local hospital. It was really nice to put some faces to the names as we've met some of the community teams here today and some of the inpatient hospitals that we refer on to. Therapy considerations. So the assessment and treatment we provide will depend on each person's needs and what matters to them. Different professions may work, in the beginning, different professions, therapy professions may work with patients at the same time. It's important to remember to keep the patient at the centre of our care. In some cases, we are unable to establish what is important to the patient, so initially it's crucial that we link in as soon as possible with next of kin and family and friends. We use a family history questionnaire to support this, and we ensure that the information from this is shared with the team, and we put this on the Getting to Know Me boards in the patient's rooms. There are multiple considerations required when having early intensive intervention to ensure that therapy is appropriate and timely. Initially, patients may be somewhat flat and tired. They're not always able to tolerate multiple interactions from different team members, so we need to be mindful of early fatigue. So sometimes it's better to complete therapy sessions with other therapists and family members. Patients can react and engage differently with their loved ones. Therefore, it's important to consider this and include family in interventions, and in particular when we're doing the formal prolonged disorder of consciousness assessments. It's important to consider short spells of therapy that may include being up to sit for short periods of time and increasing that as able. And interventions may be joint with other professions at this early stage. We consider education with staff and family regarding the importance of rest and avoiding overstimulation. Rest is just as important as therapy in the early days. We often find when we advise families that rest is a vital part of rehab and recovery, it gives them permission to not be at the bedside 24/7. We consider starting a timetable to support patients' rehab so that everyone is clear on the plan, expectation and interactions that the patient is due to have that day. So how do we know what we are doing is right? We measure and report, then we measure a little bit more, and we report again. The team as a whole, we measure using specific validated tools, which include the PCAT, the FIM-FAM scores, and the Rehab Complexity Score. We do these on admission and discharge. We also use the WIM as a team assessment for patients with prolonged disorder of consciousness. Individual professions will also use their own assessment and measures, and that they use throughout the admission to monitor progress in line with patients' wishes and goals. For dietitians, example, they use measure of strength, body composition, and dietary intake. From an OT perspective, we will use cognitive assessments, the post-traumatic amnesia assessment, and standardised formal cognitive assessments such as MOCA and the Oxford screening tool. So what are we doing next? So we're doing an MDT project, which is cross-site project with Glasgow Royal Infirmary, to identify patients that would benefit from a similar service who are not on the Queen Elizabeth site. That's been led by our physio, Jack, who's in the audience today. So she's coordinating that with staff at the GRI site. We collect data. So collecting data, as mentioned before, we do it across our team, and we also do it in our individual professions. And that's to see if we can make any improvements. We are currently reviewing the data from April 23 to 24, and we have a comprehensive database that we use to collect this information. We are constantly providing staff training about who we are and what we do. We also attend courses to ensure that our knowledge and skills is at an appropriate level to meet the patient's needs. An example of that is we have linked in with care of the elderly staff, and we now complete the clinical frailty scale for patients over 65 to investigate if frailty impacts on the potential engagement with early intensive rehabilitation. For the patients with prolonged disorders of consciousness, we're on a working group that's looking at a pathway, and we're working closely with rehab medicine consultants and therapy staff across GG&C to make sure that patients have the best possible care provided regardless of location. This is currently with clinical governance to get signed off. Feedback. We're constantly asking for feedback from patients, family, and staff. One of our neurosurgeons contacted the team regarding a patient who was under his care. The patient underwent surgery, and the consultant felt the patient would not have a great outcome. The patient had input with the team in the hyperacute service, and then following transfer to specialist rehab was discharged to a homely setting within the community, and that wasn't a care home. His feedback was very positive and complimentary as the outcome surpassed his expectations. This showed the benefits of early intensive rehabilitation. On the back of this, he then asked us to present at a neurosurgeon's team meeting regarding the team and to feedback on our data to date. This was to promote the service and also to encourage referral to the service. Last week, the team received feedback from a patient's relative, which was really nice to get. And the feedback was, the team have been absolutely fantastic, and I cannot thank you all enough for taking such good care of my granddad, as well as keeping me so informed throughout. You're all amazing at what you do, and I will be ever grateful. We're also looking at resources. So as the service evolves, we are creating resources for patients, staff, and this may include leaflets, posters, presentations, seminars. We're currently working on a leaflet for patients and family and staff with regards to the importance of rest and the impact of overstimulation. So I hope our presentation has given you an understanding of the journey we have been on and also given you information on the patients who we see. The team and service is evolving, and we feel it will continue to evolve as we review our outcomes and data. If you have any questions, please feel free to ask or contact us on the email address on the screen. Shameless PR plug. There is a permanent Band 6 OT post out to advert at present. So if this is an area you're interested in, please feel free to get in touch or come and find me. Sorry, I have no shame.
Thank you so much. Is there any questions? Any questions? Oh, you've been let off light today. You've been let off light. Could you please put your hands together for Claire and Elisabeth?